Actually, it seems like everyone was able to get in really quickly. Good. All right, I don't want to take any more time from our great speakers today. So welcome everyone to the February session of the Research Ethics and Policy series. My name is Holly Fernandez-Lynch. I'm an assistant professor in the Department of Medical Ethics and Health Policy, and I co-chair this series along with Dr. Stephen Joffe. And today we're really excited to welcome Dr. Katelin Hoskins, as well as Dr. Rinad Beidas, who will be presenting on the ethical issues arising in implementation science, as you can see here, with a focus on unintended consequences, pragmatic trade-offs, and sustainability. I'll provide just a little bit more by way of bios in a second. I'm not going to show you our usual reps intro slides today, just because we didn't want to mess with the PowerPoint. But as a reminder, these sessions will continue to be recorded unless we state otherwise. And Mary Pham has been posting the videos to our medical ethics and health policy website as soon as they're ready. We may be in person for this series starting next month in March. We will keep you posted on that, but we'll continue to offer virtual options for reps attendance. And we'll be thinking about the 2023 schedule before long. So please don't forget to let us know if there's anybody that you would especially like us to invite so you can hear their perspectives on these issues in research ethics and policy. Now, Mary will post to the chat a link to some online resources from our department. We have a series of short research ethics courses available for free continuing education credit, including some courses that can be used to satisfy your research ethics training requirements, both for the Penn IRB and the CHOP IRB. And we have a new short course in ethical issues arising in global research, which will be accessible at the link that Mary will post. Briefly, I just love to thank our co-sponsors who help make REPS possible. This is a joint effort between ITMAT, CHOP, the Abramson Cancer Center, and our Department of Medical Ethics and Health Policy. Thanks to Mary Pham for keeping things moving so smoothly for us. And now I will go ahead and quickly introduce today's speakers. So I'll first begin with Dr. Rinad Beidas, who is a professor of psychiatry, medical ethics, and health policy, as well as medicine here at PISCE. And she's also the director of the Penn Medicine Nudge Unit. In addition, she directs the Penn Implementation Science Center at the Leonard Davis Institute. Her work aims to improve the quality of health and mental health services through implementation science. And we're also going to hear today from Dr. Katelin Hoskins, who is a National Institute of Mental Health T32 postdoc fellow in the Center for Mental Health at PISCE's Department of Psychiatry. And Dr. Hoskins also maintains an active clinical practice as a psychiatric mental health nurse practitioner at CHOP. Her research is focused on improving the uptake of evidence-based practices in routine clinical care. And we're really looking forward to hearing from both of you today. Thank you so much for joining us. And for those of you who are listening in, our speakers have indicated that if you have clarifying questions, you can go ahead and put that in the chat. I will periodically check that and chime in if we need anything to be clarified. Otherwise, we will plan to leave time at the end for your questions. All right, please take it away.
Thank you so much. Can you all hear me? Can someone give me a thumbs up? Yeah,
good.
The slides look good. Awesome. So I want to start by thanking Holly and Steve for this kind invitation. We're so excited to be with this amazing group and to learn together today. I also want to thank Mary Pham, who has been amazing at helping us organize and coordinate this. So thank you so much. Really, really excited. And I'm going to kind of kick us off, but the majority of this talk is going to be led by Katie, who has taught me so much about the intersection of implementation science, bioethics, and equity. So really excited for that. Next slide, please. Just want to start off by making our disclosures. You'll see asterisks next to the disclosures related to this particular work that we'll be talking about, which is all related to NIH funding. Next slide, please. So just to get a sense of how we're going to spend our 45 minutes with you, it's going to be a whirlwind. We're going to start with a little bit of background around implementation science. We're not going to do too much there, but just to make sure that we're all on the same page moving forward. And then we are going to present some big picture questions that have been coming up for our group as we've been working through questions related to ethics, equity, and implementation science. We'll then use a particular study that we're working through, our Aspire trial, to illustrate some of these challenges and then discuss future directions and questions. Next slide, please. So first, a little bit about what implementation science is. Now, so for those of you who know me, I could spend the whole time talking about that. I'm not going to do that today. This is kind of our textbook definition of what implementation science is. It's a scientific study of the strategies and the methods to facilitate the uptake of evidence-based interventions equitably into routine clinical care. My kind of cocktail party definition is it's all about moving the needle equitably in health and making sure that folks get best practices and the highest quality care in routine care settings. Next slide, please. I'm just going to take you through a little walk through the implementation science subway line just to make sure we're all on the same page about what types of questions we really focus on in implementation science. And this is a heuristic tool that I co-developed with my colleague, Dr. Megan Lane Fall and Dr. Jeff Curran, after teaching our Introductory to Implementation Science course several times. So what you see here is our subway line. And so if you start with the red line, Katie, if you don't mind adding the stars for me, the first question that you want to ask yourself is, what's the thing or the practice of interest that I'm trying to implement, or I'm interested in whether or not it's ready for primetime implementation questions? So the first question you might ask yourself is, has this thing shown efficacy? In other words, have we seen it tested in a tightly controlled trial that's prioritized internal validity? If the answer to that is no, then you're in this efficacy space, so you're not doing implementation research. However, you absolutely can and should design for implementation by including end user stakeholders. So the red line is a separate line from the implementation science green line. Next set of stars, please. Now, let's say your practice of interest has shown efficacy. The next set of questions you might ask is, has this thing shown effectiveness in less tightly controlled trials? And if the answer to that was no, traditionally in the biomedical research paradigm, we would jump to doing effectiveness studies. So less tightly controlled studies with a broader population of interest delivered by real world clinicians. And that in itself, if you're just focusing on patient outcomes, actually isn't implementation research. So you're still not on the pathway. However, we do have a type of study called hybrid effectiveness implementation trials. And those are actually in the green line of the implementation science subway. And those are studies, and this is really important because we're going to be talking about a hybrid study for the rest of the talk today, are studies which prioritize answering questions of effectiveness of the thing or the intervention, and also understanding implementation strategy processes. And they range on a continuum, which I won't get into today, from being more focused on effectiveness to being more focused on implementation questions. So that is squarely in our wheelhouse. And then on the bottom with the stars that Katie just shared is kind of the bread and butter of what we do in implementation science, which are mixed method studies to understand the context that we're trying to implement in, and then designing and testing implementation strategies and large comparative effectiveness studies. That's real, we're up a level. We're really interested in testing the different ways that we can support clinicians and organizations in implementing things or practices. So that's the background for what implementation science is. And hopefully we're all on the same page. And if you have clarifying questions, I can answer them in the chat once I hand the baton over to Katie. Next slide, please. So today we're going to be using a particular case study focused on increasing firearm safety promotion in pediatric primary care. I wanted to share a couple of factoids for you to help you understand why this is an important use case. The first is that the suicide rate in our country for young people has been steadily increasing over the past decade. So the current rate is 6 per 100,000 youth suicide deaths. Half of those suicides are with firearms. And the thing about firearm suicide attempts is that they are highly lethal, which is different from other attempt methods. In the United States, 1 in 3 homes have a firearm, and most homes with one firearm have multiple firearms. And now, because of COVID, there has been a proliferation of purchasing of firearms in the country. And there are a lot of homes with firearms in them with new owners. We know that safe storage of those firearms can save lives based on simulation studies and epi data demonstrating that only 3 in 10 homes store their firearms in the way that's recommended, which is firearm unloaded, locked with the ammunition stored separately in a locked place. So basically, we know that safe storage programs can save lives. And if you can press the spacebar, Katie. There was a large effectiveness study done in 2008 that our group was not involved in, led by Dr. Sherry Barkin and colleagues in Vanderbilt, which demonstrated that a brief program that included screening for firearms in the home, providing brief counseling around safe storage, and giving free cable locks changed parental storage behavior around firearms. So we already know that we have a thing that can work. And so we're really at a point where we're on the green line of the subway trying to understand how to implement that. Next slide, please. So next spacebar, please. So we've done a bunch of back work here since 2015, trying to understand the context, the acceptability and use of this evidence-based practice, and also barriers and facilitators to its use. I'm not going to get into that because I really want to jump to the meaty content here, but these are the publications where we did that work, where we learned that we were ready to implement, but there are some factors that we needed to address in our implementation. Next slide, please. And so we are now at a point, spacebar, where we are focusing on doing a hybrid effectiveness implementation trial in partnership with 2 health systems, Henry Ford Health System and Kaiser Permanente, Colorado. And we're implementing an adapted version of that original intervention that we call Safe Firearm, that includes brief counseling and giving out cable locks. This is the study protocol if you're interested in reading more about it, and we will make these slides available to you. Next slide. The fundamental premise and main question of the study is the less costly and scalable electronic health record-based nudge, which we're building into their well-visit templates, powerful enough to change clinician behavior? Or do we need more intensive and expensive facilitation, which is a more resource-intensive implementation strategy, to overcome some of the implementation barriers that we heard of in our earlier formative work, particularly given that firearm safety promotion is a sensitive topic? Next slide, please. So essentially, we have 32 clinics. Half of them are just getting the nudge. The other half are getting a nudge plus 1-year facilitation. That's our nudge plus condition. And our main outcomes are fidelity as measured by parental report of whether or not they received the conversation and the gun locks or were offered the gun locks, and then reach as documented through the EHR. So I'm going to pass it over to Katie now. Mary, can you try to unmute? Yep, perfect.
All right, sorry about that. And do you guys have the correct view?
We see your slide deck, but not in presentation view.
All right, I'm gonna switch that over. How's that for everyone?
We can see you and hear you great.
Terrific. All right, great, everyone. So thank you again so much for having us here. I'd like to start our discussion with a call to action for implementation researchers to attend to ethics and equity in study design, execution, and sustainment. And I'm really excited for this opportunity to present our thinking in this space. And this is early thinking. We really encourage and welcome your expertise as we continue to think through these issues in more detail. So there's 3 overarching questions that I've been thinking through to further inform this call, and would very much welcome your input later on in the discussion today. The first is, how do different disciplinary traditions inform the current equity-oriented discourse within implementation science? Over the past few years within implementation science, there's been significant attention to health equity and how implementation science must give higher priority to health equity in order to serve as a vehicle for more just care. And what I've found interesting in observing this discourse is that advancing equity isn't necessarily being framed explicitly as an ethical issue. The bioethics canon doesn't seem to be a referent for implementation scientists doing justice-oriented work. And I wonder how much of this is team composition, familiarity, lexicon, or perhaps less emphasis historically on social and structural drivers of health outcomes within the bioethics literature. And I'd like to think about how these disciplinary traditions can be brought together to accomplish shared goals. Second is, to what extent do implementation research outcomes overlap with ethical values? So here's a visual of Enola Proctor and colleagues' classic conceptual framework for implementation research. And I've added stakeholder engagement across the top to reflect this core tenet of implementation science. And you can see here intervention strategies, which are basically the evidence-based interventions or practice of interest. Then implementation strategies, which are the how of implementation. These are our interventions within implementation science. And outcomes, which can be divided into implementation outcomes, service outcomes, and client outcomes. And what's interesting is that some implementation research outcomes, specifically sustainability, equity, and acceptability, of framing acceptability as a signal of respect or welfare, which I'll touch on later, seem to overlap with ethical values, several of which are delineated in this fantastic ethics and research guide from the WHO. And I think there's space for thinking through how outcomes and values are framed and interpreted within implementation science with an ethics lens. And third is, how are expressions of investigators' values reflected in scientific design decisions? We'll see in the 3 case examples that I'll walk through from the Aspire trial, we see ethical features are suddenly woven into research design and execution challenges, and pulling them apart can help us take a closer look. So in this first example from the Aspire trial, we'll discuss implications for equity. In the second example, we'll talk about implications for respect. And in the third, we'll talk about implications for sustainability. So let's start with this first example on unintended consequences related to outcomes with implications for equity. So this was about a year ago, and as some background context, during early pre-trial stakeholder engagement, clinicians provided feedback to the research team that the Safe Firearm program may not be delivered evenly to all children, with potential variation by children's medical complexity due to competing demands that may come up in the clinical encounter and crowd out counseling on safety topics. So for example, a child considered medically complex may have both asthma and major depression. They also alerted us to the potential for uneven delivery by race and ethnicity, given extant disparities in children's health and healthcare stemming from structural racism. This feedback generated important questions with ethical implications. So benefits predicated on program delivery and receipt. If children are less likely to, clinicians are less likely to deliver the program to children who are already disadvantaged, these kids benefit less. And conversely, if more advantaged children are more likely to receive the program, they may accrue greater benefit, which generates differences in the distribution of the magnitude of benefit across groups. And it's this possibility of widened disparities via differential rates of program delivery that really primed our team to consider the potential unintended consequences of implementation, particularly related to equity. So we wrote an administrative supplement to the R01, which was funded, and deployed a pilot study last fall to examine any signals of disparities in program delivery. In the pilot, the EHR nudge was deployed in 5 clinics over a 1-month period. Now, data analysis is ongoing right now. We're really eager to see the results, and we expect that the results will help us consider how to adapt the nudge plus strategy, which is that EHR nudge plus practice facilitation, to increase the likelihood of equitable outcomes in the trial. So you can think about unintended consequences as either positive or negative spillover effects on processes and outcomes that occur with any change in a complex system. And there's been attention to unintended consequences, particularly negative unintended consequences, in implementation research in multiple forms. So the standards for reporting implementation studies, or the STARI statement, advises reporting on all important harms or unintended effects in each group. The explanation notes that the adverse or unintended consequences of implementation studies are often underreported and as such should be reported and quantified with the possible reasons identified. The WHO Ethics and Implementation Research Guide, which I mentioned a couple minutes ago, further delineates unanticipated or hidden harms that extend beyond the individual and can include social harms like stigmatization, financial, communal, and health system harms. And in the REAIM extension, which is a key evaluation framework in implementation science, a key consideration is whether there's any negative and or unintended effects of implementation. And this certainly isn't a new concept. Back in 1938, the sociologist Robert Merton wrote about the unanticipated consequences of purposive social action. And he highlights this terrific phrase, the imperious immediacy of interest, where the actors or the researchers' paramount concern is with the foreseen immediate consequences and excludes the consideration of other consequences of the same act. And this might be very rational in the sense that it's an action which may be expected to lead to attainment of a specific goal, but irrational in the sense that it may defeat the pursuit or attainment of other values, which maybe not at the moment are paramount, but nonetheless form an integral part of an individual's scale of values. And this idea very much aligns with implementation science tenets that emphasize that our actions aren't carried out in social vacuums and really calls teams to examine the values that inform their scientific decision-making. A key challenge, though, is that there's limited guidance on how to identify and evaluate negative unintended consequences, despite them being ethically important. So in terms of identification, there's difficulty anticipating, especially within the constraints of clinical trials with pre-specified goals and measures. Some have argued that the NIH should provide better support or more support for the collection of unintended consequences data for direct and indirect, so collateral trial participants. There's also challenges with feasibility and inclusion of outcomes that are relevant for stakeholders, as well as potentially different interpretations of harm based on the actor. So a health system leader versus a clinician versus a patient. Who ultimately decides what's unacceptable, what's important, what's meaningful? And there's also concerns about equity harms, which are most relevant to our case in terms of disproportionate distribution of the benefits of interventions. And notably with equity harms, no single person may be made worse off or directly harmed by the intervention or implementation. The key matter is really the size of the benefit. And this may impact groups with the least social and political leverage, which is problematic. There's also this question of the extent of researcher obligations to avoid or to mitigate. What does this look like very practically? So for example, studies designs accounting for time-varying adaptation, running pilots and adapting implementation strategies like we're trying to do, improving stakeholder engagement, or refining program theory to better understand mechanisms. There's certainly a lot to unpack and think through more here in this space. So next, we'll take a dive into some of the pragmatic trade-offs that can arise in implementation research, design, and execution, with implications for respective stakeholders' preferences, goals, relevant outcomes, and their needs. So as a second example from Aspire, EHR delivered behavioral economic strategies have been used to change clinician behavior and are highly promising. Our research team co-designed the EHR nudge with clinician stakeholders across both health systems. This nudge is being added to all well-child EHR standard templates so that every pediatric primary care clinician who sees patients for well-child checks will have this nudge available to them in their template. So this process very much involved navigating preferences from both health system sites and the research team. And for those of you who haven't spent a lot of time in EHRs, there's a lot of different features to sort through. The EHR nudge at each site had a different form and that it looked different, but a similar function in that it served as a prompt to deliver counseling and offer locks to all families. Clinicians need to indicate what's completed during their visit in order to close out their notes. During our pretrial pilot, in which that nudge was deployed over a 4-week period across the 5 clinics in both health systems, we heard from clinician stakeholders at one site that they'd like to modify the nudge. They indicated that the current form was too burdensome and proposed changing the responses to a default yes, that the program was delivered. Now, just to contextualize a little bit more, extra keystrokes in the context of hugely busy primary care clinics during a pandemic, no less, is a real concern. We know that frontline clinicians have been operating at full throttle for at least 2 years, and many are experiencing burnout. Changing the nudge to a default is an open question empirically. It may signal the expected behavior, but clinicians might also keep the yes option without actually delivering the program. Our team ultimately decided to change the nudge to promote acceptability of the strategy, reduce burden on these clinicians, and respect these stakeholders' input. And what comes with this then is the challenge of balancing respect for and responsivity to preferences and maintenance of scientific rigor in strategy design. The goal of infusing behavioral economics into strategy design is to steer clinicians and make it easier to make the evidence-based choice. Some have argued that nudge strategies should be transparent, and in our case, clinician stakeholders participating in the pilot all understood the implementation strategy and its function. There were no concerns explicitly for any interference in self-determination, as we can sometimes hear with nudge strategies. Here, the concerns were more related to welfare and the stresses experienced by clinicians doing the day-to-day work of care delivery. And we can think about the implementation outcome acceptability, which is defined in implementation science as the degree to which an intervention or strategy is palatable or satisfactory, as one signal of welfare or well-being. Poor acceptability can undermine effectiveness, and then strategies can backfire. So close consideration is required for respecting stakeholder input, being responsive to their interests, and reducing burden on the targets of behavior change, with the target behavior being delivery of evidence-based interventions. But there also needs to be caution for not over-relying on stated preferences if the rigor of the science is overly diminished. Strategies need to be aligned with theory and powerful enough to test in an RCT, which is important for other ethical goods like stewardship of resources. Researchers also need to consider the thresholds of burden when there's evidence to suggest that strategies can support improved outcomes for patients. And we see this tension also with another example of accountable justification, which is a different EHR-based implementation strategy informed by behavioral economics, where clinicians must provide an explicit rationale for making a less desirable choice. There's evidence to support this strategy's use, but acceptability may be low depending on the context, with concerns for workflow and frustration that may come up. Overall, the process of eliciting preferences is an important way to integrate the deep experiential knowledge of stakeholders and strengthen the outputs with an eye towards scale-up, but careful deliberation is required along the way. And our case really highlights how early engagement is key. So if we telescope out a little bit more from strategy design, another challenge more broadly with implementation research, design, and execution is related to navigating respect for and responsivity to different stakeholders' goals. So diverse perspectives we know are essential to the work of translating evidence-based practices into routine care. It's important for acceptability of proposed interventions, optimizing uptake, ensuring inclusion of marginalized populations, establishing accountability processes, and ensuring that individuals are aware of rationale and opt out if there's no individual level informed consent, which is a whole separate discussion. We can also see, though, logistical and ethical challenges in co-producing research. Some ethical challenges include deciding who should be considered a researcher versus who is being researched, which is important given the large teams that are often involved in implementation research studies. With that comes the need to identify different interests, identify responsibilities, and consider who's affected in morally relevant ways by the research. And with that comes different rights and responsibilities that may then be owed. Power dynamics inevitably infuse these relationships. There's embedded hierarchies and goals from health system leaders, clinicians providing care, and community members that are impacted in other ways by implementation that may come into conflict. And with this is a need for investigators to balance potentially misaligned or competing goals from different stakeholder groups. There's limited guidance on the best way to do this in terms of weighing, negotiating, and responding to various goals. Another challenge within study design and execution is elevating respect for and responsivity to outcomes that are most relevant for patients. As you all know, primary data collection is time and resource intensive, but it's often a way of getting to outcomes that may matter most for patients. And when thinking about explicitly integrating equity considerations within pragmatic trials, the outcomes assessed must be relevant and important to groups experiencing inequities. Patient-reported outcomes and perspectives on their care experiences may also be important for equitable scale-up. So for example, in Aspire, our primary outcome variable is fidelity or parent-reported program delivery. We're using parents as chief informants of clinician behavior. Parents' views are really key here. But in our pre-implementation work, we found that post-visit survey response rates have been low, and creative efforts to increase responses have added additional burden to our partner sites. Concerns for non-response bias may preclude us from keeping this as a primary outcome. Beyond this case, routinely collected EHR and administrative data have huge value in pragmatic trials, but may not include the outcomes that are most relevant to and centered on patients. Amid time and budget constraints, investigators inevitably need to prioritize. And one other set of issues in design and execution relates to the challenge of ensuring respect for and responsivity to local values in intervention design and implementation. Implementation science highlights the need to maintain fidelity, that is, to deliver the evidence-based intervention as it was designed. Poor fidelity can attenuate effectiveness. But we also need to adapt and flex and learn lessons during implementation, especially during scale up and with changing contexts. Adaptation to unique settings and populations can reflect respect for local community values and meet needs, and can also improve outcomes, but can lead to drift from core components that contribute to effectiveness. In our work, we engaged in an iterative adaptation process to engage key stakeholders, including firearm owners, to adapt the Safe Firearm program with the goal of respecting the diverse perspectives of these constituents and optimizing the effectiveness of our approach. Adaptation has maintained the core components, so the active ingredients of the program, which is that brief counseling and free cable lock offer, while modifying the periphery to align with parent and user needs, as well as their values around child safety. So in this next example, we'll talk about health system integration and implications for sustainability. So as highlighted in our prior section, upfront engagement with stakeholders has been essential, and this has included partners through multiple levels of the health systems. Our partners were committed to adopting Safe Firearm and using the nudge or the EHR prompt, but we needed to talk about Nudge Plus, the implementation strategy that's more expensive and time intensive. The trial uses an innovative approach that tests 3 hypotheses simultaneously: equivalence of Nudge and Nudge Plus, superiority of Nudge Plus, and non-inferiority of Nudge Plus. In order to do this 3-sided statistical test, we needed to pre-specify the equivalence margin. Essentially, what does it mean for Nudge Plus to be better than Nudge? We looked into the literature, but certainly this was a values-infused decision with implications for widespread adoption. We needed input from clinician stakeholders and health systems leadership. What difference between the 2 conditions is meaningful? And preliminarily, what could health system leadership commit to for widespread use post-trial. Cost and system burden were key points from leadership. The literature provided a little bit of guidance. A simulation study found that a 20% gradient where increased locking was protective in saving lives, but this wasn't real world. And several clinicians indicated that any increase in counseling was positive from their perspective, especially given that the intervention's brief. Many of them anchored on the number of lives saved, but this number is challenging to calculate due to low prevalence, and one child's life makes all of this work important. Ultimately, we received input that a 0.1 change in the probability of fidelity, so basically a 10% increased likelihood of clinicians delivering the program compared to pre-implementation, was meaningful for these two large health systems. These were complicated conversations that took several months and critical not just to the statistical analysis, but setting the stage for continued use beyond the trial. It also raises questions about who's involved in deciding whether or not to scale interventions and strategies. So sustainability is defined in implementation science as the extent to which a newly implemented intervention is maintained or institutionalized within a service setting's ongoing stable operations. It's a key implementation outcome and goal of implementation research. A key challenge comes in conducting studies with a vision for sustainable scale up and rollout, particularly amid resource constraints. Scale-up's considered a key ethical proposition of implementation research. And given that implementation and scale-up require resources, issues related to material power within organizations, communities, and systems come into play, which raises key questions over who has control over and distribution of critical resources. Stakeholder and community engagement and planning stages is essential for identifying priorities, gaining buy-in, and establishing commitments to sustain and scale up the evidence-based intervention. But the obligation is not necessarily just for the researcher, but other stakeholders too, including local policymakers, providers, health systems officials, and finance actors. A unique consideration for implementation research is the sustainability of the intervention plus the implementation strategies. The complexity and cost of the strategies is also key. Implementation research has a strong health system strengthening focus. It aims to create horizontal integration in health systems so that the benefits aren't just siloed within organizational pockets. So for example, within the ASPIRE trial, we hypothesized that Nudge Plus, so the Nudge Plus implementation strategy, facilitation, will increase practice adaptive reserve, which is the ability to make and sustain change at the practice level. And there's previous research to suggest that facilitation improves relationship infrastructure, aligns practice operations, and improves the work environment, which has potential implications for other evidence-based interventions. The RE-AIM extension adds an important lens to sustainability explicitly from an equity perspective. What settings and populations continue to be reached long-term and continue to receive benefits over time? Do adaptations to evidence-based interventions reduce or exacerbate inequities over time? And are the determinants of sustainability the same across low resource and high resource settings? If access can't be assured for a community after the research is complete though, so there's no possibility of sustainability, it may not be ethical to carry out the research or test the evidence-based intervention in that specific context. Potential sequelae of implementation research with unsustainable interventions and strategies may include exacerbation of inequities, harmful effects to communities, or loss of trust in the broader research enterprise. But an important consideration for researchers is not to select exclusively better resource settings. And there's questions around the potential justice implications for generating knowledge. So as a few other ripe ethics topics within implementation science that aren't as explicitly linked to our case, that I think interesting to think through a little bit more. The next briefly relates to evidence for the research to practice gap. So implicit within decisions to introduce or remove healthcare is an expression of values. There's a sociopolitical nature of applying evidence in practice. Prior to implementation, a key step really is critical evaluation and scrutiny of the evidence-based intervention. Is it actually effective, and for whom? This is especially concerning given skewed representation in trials. Recommendations for reframing implementation research with a focus on justice and racial equity include consideration of expanding our evidence base to community-defined or practice-based evidence when defining and identifying evidence-based interventions for addressing structural racism. As an extension of ethical issues around stakeholder engagement, this brings up a key point related to epistemic power. Whose knowledge is valued throughout implementation? Epistemic power is enacted in the selection of evidence used to inform implementation decisions, and who deems that evidence as valid in different implementation contexts. And it's explored further in this brilliant paper here led by Megan Stanton that I would point everyone to look into this a little bit more. And lastly is the concept of equipoise. So clinical research that tests the effectiveness of a novel intervention using an RCT must uphold the ethical principle of clinical equipoise, which is genuine uncertainty within the expert medical community about the efficacy or effectiveness of the preferred treatment, which is underpinned by the principle of beneficence. Seward and colleagues argue in this paper here that in implementation research in low and middle income countries, there may be a different ethical concern. Equipoise may no longer lie in the clinical effectiveness of the intervention, but in how precisely to implement it in a new context. As such, for implementation research that uses an RCT to test the effectiveness of the implementation strategies to deliver care that's known to be clinically effective, clinical equipoise isn't any longer applicable. It's contextual equipoise then, that's the genuine uncertainty whether the implementation strategies will effectively deliver the evidence-based intervention in a new context, and really attends to effectiveness of implementation processes. The authors emphasize the importance of evaluating and reporting the influence of context on implementation strategies in order to improve our ability to generalize findings beyond their original settings. And there's an opportunity to really dive into this more to better understand and further develop this concept. So as we close, I'll highlight some future directions for empirical work at the intersection of implementation science and bioethics. And going back to this first case example that we discussed, back to unintended consequences, our team plans to build on these questions, to deepen our understanding of how to characterize, identify, evaluate, and mitigate the negative unintended consequences of implementation. We're beginning a qualitative study with a sample of implementation scientists, bioethicists, and health equity experts to bridge disciplinary expertise in this space. We'll use this conceptual framework on the adverse effects of public health interventions from Thea Lorenk and Catherine Oliver, which proposes categories for considering potential unintended harms of interventions, including direct harms, psychological harms, opportunity harms, social harms, and equity harms. Given the multi-level nature of implementation, unintended consequences can be conceptualized at the individual patient, clinician, organization, and community ecological levels. Multi-level frameworks within implementation science are a real asset for exploring the multiple facets and manifestations of unintended consequences. And we hope to build a taxonomy to inform equity-oriented implementation research across diverse settings, including community and health system-based sites, and hope that this work can inform implementation research reporting and further exploration of avoidance and mitigation efforts. So I'd like just to highlight and thank the Aspire study team. This is an incredible group of researchers led by Rinad that has approached this trial with such care, intentionality, and thoughtfulness. It's been such an honor to learn from them. And I'd like to bring us back to this discussion here and would love feedback on this is 4 points. How do different disciplinary traditions inform the current equity-oriented discourse and implementation science? To what extent do implementation research outcomes overlap with ethical values? How are expressions of investigators' values reflected in scientific design decisions? And where do you all think there's opportunities for further exploration of other issues related to ethics within implementation science? So thank you all so much for this opportunity to present today. It's been a great opportunity. Look forward to the discussion.
Great. Thank you so much. And especially thank you for leaving a lot of time for discussion. So I will invite people to continue posting questions in chat. I think that actually, Steve, we should start with you. You posed a question in the chat that Rinad suggested maybe would be good for discussion. So do you want to just state it out loud and we can have a few minutes on that?
Sure. Can you hear me?
Yes.
Yeah. You know, the issue is the example, it's a great example that you talked about to raise all of these issues, was focused on achieving outcomes related to firearm safety. But in your sort of implementation and thinking about it, all these questions related to equity came up as, afterthoughts is not the word, but they came up as sort of secondary considerations where that was not the primary goal. So I'm wondering, you can envision that there might be situations where the primary problem you're trying to solve is or improve is an equity problem, and it's not enough to sort of develop efficacy strategies to address equity challenges. You then got to figure out, can you implement them successfully, and what does it take to do that? So I'm thinking about, and I saw that Scott Halpern also may have some contributions or thoughts on this, that some studies might explicitly be implementation science studies aimed at addressing equity challenges as a primary aim, not studies that raise equity issues in the service of other ends. So I just wanted to raise that as a sort of additional consideration for discussion.
No, I appreciate you raising that. And I think it's been interesting too, seeing as we've had more discussions with the implementation science where health equity fits into those conversations, whether equity is an upfront explicit consideration versus something that comes up later in the study due to challenges that emerge, or is really brought to the front through interdisciplinary collaboration and bringing large groups of people together to address really complicated issues and better understand them. So I think we've seen different directions in terms of whether this is an explicit upfront consideration or something that comes up that's recognized as really critical to address and tackle head on. So Scott, I see you too, and I would love your thoughts on this as well.
Sure. So first, great presentation. I mean, really highlights a lot of the really core issues at stake here that I think have, as you said, received insufficient attention. So a lot of the work that we've been doing is actually designed explicitly to promote equity as a primary implementation aim, with in fact primary outcomes being mitigation of whether it be a racial gap in receipt of services such as palliative care, specialist palliative care consultation, or otherwise. And you know, I think one of the main virtues of nudge-based EHR interventions is exactly that. It removes implicit clinician bias from the equation. Well, I shouldn't say it always removes it, but in the worst case should mitigate its influence. And designing interventions that may even sacrifice a degree of effectiveness for a greater service in promoting equity is an interesting trade-off that can and I think should be explored as a primary goal.
I would just add that I think in the past 2 years, there's been increasing, rightfully so, attention to incorporate that explicit equity lens from day one into the work. And a key aspect of that is identifying existing disparities and including a focus on equitable outcomes as part of the primary aim. And there is a continuum, right? I mean, I think there are studies that are explicitly focused on implementing an evidence-based practice to reduce the disparity. But even if that's not the focus, we should always be attending to potential disparities that we could either reify or widen. And so I think we need to be explicit about what we're trying to do in our studies and always have that equity focus front and center.
Yeah, it's really analogous, Rinad, to a related topic in the artificial intelligence machine learning world, where once the issue of algorithmic equity came into prominence and a lot of examples of ways in which predictive models were inequitable, the approach initially was to, well, you design a model and then you later evaluate its equity. But there are actually now approaches that have been developed that we favor, where you actually explicitly model equity in the development stage of the model and will in fact set parameters for reduced predictive performance in the service of greater equity before rolling something out into clinical practice.
Great. Well, while I wait for folks to chime in with questions or comments, I have several that I'll just throw out there, and you can decide which ones you'd like to respond to. So first, I'm really curious about the kind of questions you get from IRBs when they are reviewing this kind of implementation science work, right? I could imagine, I could imagine an IRB being concerned, oh, you're going to test something that you already know works. How are you going to do that? How is that reasonable? So that's one question. The other that I'd be interested in your thoughts on are how we should be thinking about resource allocation between effectiveness, efficacy, and implementation research, right? And is there a way to kind of merge those things? Do we have to kind of bucket them into different categories when you think about, going after research funding, for example? So let me stop there and see what you think.
Well, that's such an interesting question. I appreciate that. I'll just touch on the second one in terms of how we think about resource allocation. I think what strikes me as so important and valuable about implementation science is trying to take all this that we know is effective and actually getting it out into use into the real world, and that translational piece. And that to me feels so important in terms of moving the needle, in terms of improving outcomes down the line. And so when I think about where we put our resources, I think there's so much space in terms of thinking about implementation and taking what we know and actually getting it out there into use. I think that hybrid trials are really interesting in terms of how can we think about testing effectiveness in conjunction with testing implementation. So having both of those ends in mind as an opportunity to really more quickly translate what we know into what we're doing on a day-to-day basis. So I think greater use and attention to those types of designs when we're looking at both effectiveness and implementation factors has a lot of value for investigators thinking about doing more work within this space. Nat, I don't know if you have other thoughts you'd like to add as well.
Well, first of all, excellent answer. I love this question, Holly. It's such an important one. And I just want to lead by sharing my bias, which is obviously that I'm an implementation scientist. So I think that we should be allocating more resources to implementation, which has a conflict of interest inherently bundled into it. But does anyone want to take a guess in the chat around what percentage of the NIH budget goes to this type of work that we were describing today? So, implementation research. Anyone want to be brave and throw out a number?
I have no idea. I'm gonna say 10%.
And I see Steve wants to round up. Sassy says 15. Kelly says 10. Okay, so it's actually less than 1%. And so I'm basing this on a study that the NCI shared of their portfolio, and the NCI funds the most implementation research across the institutes within the National Institute of Health. And so, I think that we really woefully underfund the work that is needed to translate the scientific discoveries into things that actually benefit our communities. And there's two papers that came out in this past year that I think just make this point really salient. One is a simulation study by Peltiel et al., which was a top 20 health affairs paper from I think 2020 or 2021 that basically looked at simulating what was more important, the efficacy of the vaccine or the implementation approach. And obviously we know how that played out, so I don't need to tell you that. And then the other was an editorial that just came out in Science we finally made it into science by Drs. Enola Proctor and Elvin Gang from WashU and St. Louis, basically making the case that we really woefully have underfunded understanding how to implement discovery. And so, you know, I'm not saying we should like just go all the way over on the pendulum, but I think that it would be really lovely to see an increase in, you know, our federal budgets focused on this question, which is, you know, about behavior change and structural changes and community engaged work. And I think the hybrid trials are where it's at. And I have a fairly controversial opinion that I'm not really interested in efficacy studies. Again, I'm biased, but like if we can't make the thing work in the real world, it doesn't really matter to me that it'll work in a really pristine environment that's tightly controlled. Like I want to test things, develop things in partnership with the community and stakeholders that work in the settings in which they're supposed to work for the people for which they're supposed to work. And so that's just my own soapbox. I'll stop there.
So one really interesting issue that your whole talk raises is that in research ethics, we typically think about what's the social value of exposing research participant to risks and burdens, right? You know, so that's what the IRB is supposed to be doing. Researchers have an obligation to make sure that, you know, risks are minimized and benefits maximized. And yet we often hypothesize, right? Like, oh, if this trial works out, then the social value will be achieved, and that will justify the risks and burdens that we've imposed on these research participants. But there's so much kind of guessing and hope, right? Because it's missing that idea that social value relies on actually implementing things. And I think that that's really lost in the research ethics oversight world, at least anecdotally. Not so much a question, but please, if you have thoughts about that, by all means.
There's a great paper out of WashU on the Society Translational Benefits Model by Doug Luke that kind of talks about the impacts that our work should have that I think should be explicitly tied up in what you're saying. But it looks like Katie wanted to add something, and I'll put it in the chat so people can look at it.
Oh, the thought that came to mind for me was just thinking about calls to better report and identify what are we doing in terms of implementation strategies that are unfolding within effectiveness trials so that we can better understand what's actually the processes behind the testing and development of interventions, so that when we're thinking about scaling and taking it beyond, we have a sense of implementation processes as well to support that translation down the line.
Well, great. We are at time. So thank you for such an engaging discussion, a really great overview of the ethical challenges that are arising in your work. And I will invite everyone to please join us for the next REPS session, which will take place on March 7th. We're going to hear from Claire Hankinson, I think our first ever animal research session. So I hope you'll all join us for that, and perhaps we'll be in person. Thanks so much.
Thanks.
Thank
for
you.
having us.